the other question now, moving to sequencing, is if you started with a combination where the PD-1 inhibitor is used as frontline, you know, what do you do second line? We know that single agent TKIs, cabozantinib, axitinib, you know, all these have activities. We know they have activities from retrospective and some prospective, you know, studies. But the question, should we continue to use the PD-1 inhibitor, the same, different PD-1 inhibitor? You know, what's the combination rate? And now we're starting to see these combination coming. There was a study, a retrospective study with nivolumab, ipilimumab, post patient that got, you know, other immune checkpoint inhibitors, so the response rate less than 20% from Dr. Rini and colleague. There's another one we presented at ASCO showing a response rate 15%, a fraction RCC, which all could be honestly the ipilimumab alone. You know, we don't know that. But the question, do we need or not the PD-1 inhibitor to continue or to change? Or these drugs are still around and, you know, it doesn't make sense to change from one to another. There could be interchangeable. I don't know. But there are studies like CONTACT-3, for example, which ask the question post PD-1 inhibitor, if we do a TKI, in this case cabozantinib, versus cabozantinib plus a PD-L1 inhibitor, atezolizumab, does adding atezolizumab is, you know, we've seen some data coming from Dr. Ravi, who's in our group, that if you use a PD-1 inhibitor after PD-L1 inhibitors or PD-1 inhibitors, you can, in subset of patients, have responses. But this is, you know, retrospective studies, how did the patient cancer progress on first line or it wasn't. So I think with how many PD-1 and PD-L1 inhibitor being investigated in renal cell, it's very reasonable to have a randomized studies to answer the question.